Hi everyone, this is Dr. Sangeeta Chaudhary and once again I welcome everybody to my channel. In my today's class, I am going to discuss about the remaining portion of heart failure. So in the heart failure, today I am going to talk about the diagnosis of heart failure and also the management part of heart failure. So let's talk about the diagnosis. How do we diagnose a case of heart failure? When we suspect heart failure from the clinical presentation and examination, we go ahead first with a chest x-ray. Chest x-ray PA view. What are the important information it will give us? Chest x-ray may show cardiomegaly, that is the enlargement of the heart. It shows Curly's line. They are very important feature of heart failure. Curly's line A and Curly's line B can be seen. Most commonly Curly's B line. It is very important in cases of heart failure. Pulmonary congestion. There will be pulmonary congestion due to left heart failure. Bed wings appearance will be there. Haziness. Cephalization of veins, that means prominence of the upper lobe veins will be there in the lungs. And pleural effusion, I have already mentioned there will be bilateral pleural effusion where right sided effusion will be more than the left sided effusion. So these are the radiological finding from chest x-ray. In this x-ray we can see that there is a huge cardiomegaly. Okay, the cardiac shadow is much enlarged. So this is one of the sign of heart failure from chest x-ray. It is one of the sign in the Framingham's criteria for heart failure also. And in the next image we can see that there is bat wing appearance. This is known as the bat wing appearance, where there will be haziness in the bilateral lung fill, and the haziness will look like as if it is radiating from the hilum. This is the hilar region, so there will be radiation like pattern of haziness from the hilar region. This is known as the bat wing appearance. Okay, so these are the very important findings from chest x-ray we can look for. Next we will do an ECG, electrocardiogram. In electrocardiogram, what are the features we can see? We can see there will be left atrial enlargement. Left atrial enlargement is identified by a wide P wave. Okay, the P wave in ECG will be widened. Wide P wave means duration of P wave will increase. Okay, this I have already discussed in my class of in my ECG lectures. There will be arrhythmias. There may be bradyarrhythmia or tachyarrhythmia. There will be hypertrophy of either left or right ventricle. That also can be identified from the ECG. I have already discussed in my ECG class. In my description box, I will give you the link for ECG class. You can go ahead. Previous myocardial infarction signs also will be there. So these are the signs of heart failure from the ECG. Now I was talking about Curly's line. So what are the Curly's? Basically Curly's B line in case of heart failure. This is a normal chest x-ray, and in this particular x-ray you can see that there are small line. For example, this one. Okay, small lines are there. These lines are perpendicular to the pleura. Lines are like this. Okay, so they are perpendicular to the pleura, and Curly's B line is always situated in the periphery. They are usually found in the lung base. Since they are found in the lung base, the term B is given. So lung base in the periphery, and they will be perpendicular to the pleural surface. So this is the Curly B line which we can identify from the chest x-ray in cases of heart failure. Next, what we will do, we can do an echocardiography. From the echocardiography, we can find out the systolic and diastolic function of heart, left heart and right heart. We can calculate the ejection fraction. Ejection fraction will give us an idea of systolic function of left ventricle. And from the ejection fraction, we can categorize the patient as having heart failure with preserved ejection fraction and heart failure with reduced ejection fraction and heart failure with moderately reduced ejection fraction. Okay, so these are the criteria. These are the ejection fraction importance. And then any valvular abnormality is there or not, that we can find out, because valvular abnormality can also give rise to heart failure. and if there is any sign of previous myocardial infarction, which can be identified by abnormal wall motion of the left or right ventricle. So these are the echocardiographic features which will help us in case of a heart failure. MRI can be done. This is a higher level investigation. It is the gold standard for assessing cardiac mass or volume. Next, we can do exercise testing. Treadmill or bicycle exercise testing is useful for assessing the need for cardiac transplantation. Okay, so this is important. Then we can go ahead with blood investigation like biomarkers. There are biomarkers for heart failure which we can look for. If BNP, that is brain natriuretic peptide, brain natriuretic peptide, as the name suggests, natriuretic peptide means they help in natriuresis, means they help in excretion of sodium in water. So if the brain natriuretic peptide level is less than 100 picogram per deciliter and NT-proBNP, NT stands for N-terminal proBNP level, if it is less than 300 picogram per deciliter, that means there is no heart failure. But if BNP level is more than 500 and NT-proBNP more than 1000, then there is 80% chance of having heart failure. So we need to remember the sensitivity of BNP and NT-proBNP also. So if less than 100 and 300, there is no heart failure for certain. Other higher level studies as nuclear studies can be done. Nuclear SPECT imaging, this is a stress testing. Nuclear SPECT imaging can be done to find out if there is any ischemia at present or if there is any previous myocardial infarction, and assessment of LV function. Pulmonary artery catheterization, it helps us for the direct measurement of right atrial and ventricular pressures, pulmonary artery pressures, pulmonary capillary wedge pressure, and calculation of cardiac output and systemic vascular resistance. Coronary angiogram is very useful to find out if there is any coronary artery blockage resulting in myocardial infarction and thereby resulting in heart failure. So these are the specific investigation for heart we will do to find out if there is any sign, any thing to do with heart failure. Okay, we can diagnose heart failure from the above investigations. Routine test we will do for any heart failure case. We will do a complete hemogram, serum electrolytes, serum creatinine, liver function test, blood sugar, lipid profile, and thyroid function test to be done to find out if there is any comorbidities or precipitating factors for heart failure, because anemia can lead to heart failure, then electrolyte imbalance may lead to arrhythmias which can lead to heart failure, then renal dysfunction can lead to heart failure. Liver function test can also be done, should be done, because there will be congestive hepatomegaly leading to rise in bilirubin. Blood sugar to be checked because diabetes is an important precipitating factor for heart failure. Lipid profile, dyslipidemia is very much associated with heart failure and coronary artery disease. Thyroid function test, thyrotoxicosis, hyperthyroidism all may give rise to heart failure. So these routine investigations are also very helpful to identify different precipitating cause of heart failure. Coming to the last part, that is the treatment. How we can treat a case of heart failure. Our aim should be to improve symptoms and quality of life and to decrease likelihood of disease progression, to reduce the risk of death and need for hospitalization. So these are our goal. How do we manage? Management for purpose, non-pharmacological interventions are there. What are the non-pharmacological intervention we should advise? We should advise for a good diet. How we can advise for diet for a heart failure patient? The diet should be low in salt, low in fat, rich in fruits and vegetables, increased fiber content, water intake limited to 1.5 liters. So these are the dietary modification we can ask to a patient of heart failure. Smoking cessation. Smoking aggravates heart failure. It should be done. Smoking should be stopped. Limit alcohol consumption, and regular physical activity is very, very important. Exercise training for at least 30 minutes of aerobic exercise or brisk walking with 5 days in a week and ideally 7 days a week to be done. So these are the non-pharmacological interventions we can advise to a patient. Diet, physical activity, smoking cessation, and limit alcohol consumption. Now, heart failure with preserved ejection fraction. I will not go into the detail of this chart. I will tell later on how do we manage a case of heart failure with preserved ejection fraction. First, let's see heart failure with reduced ejection fraction. What are the drugs we use? We can use angiotensin converting enzyme inhibitors, that is ACE inhibitors, like lisinopril, enalapril, captopril, and translapril. Angiotensin receptor blocker, that is ARB. We can use losartan, valsartan, candesartan, aldosterone antagonist, that is mineralocorticoid receptor antagonist. Eplerenone, spironolactone can be used. Beta blockers, metoprolol, carvedilol, bisoprolol can be used. Arteriovenous vasodilators like hydralazine isosorbide dinitrate combination and fixed dose hydralazine isosorbide dinitrate. Angiotensin receptor neprilyzing inhibitor, that is ARNI, can also be used. Secuvitril and valsartan. Valsartan is the ARB, that is angiotensin receptor blocker, and secubitril is the neprilysin inhibitor. Okay, neprilysin inhibitor. So this is a very important drug to be used for heart failure with reduced ejection fraction. So we use AC inhibitors, we use ARB, we use mineralocorticoid receptor antagonist, we use beta blockers, then we use vasodilators, okay, and then we use ARNI in case of heart failure with reduced ejection fraction. These are the drugs to be used. We can remember these drugs. Sometimes we will need to use ivabradine to control heart rate. If heart rate is not optimum with use of beta blocker also, there is heart rate, if it is more than 70 per minute already on maximum beta blocker dose, then we can use ivabradine 2.5 to 5 milligram orally twice daily we can use. Actually, it inhibits the pacemaker automaticity. It inhibits the late sodium entry in the pacemaker action potential. Okay, thereby it will limit the heart rate. And if there is any contraindication to beta blocker use, we can also use the ivabradine. Okay, now a patient of acute heart failure, acute ADHF stands for acute decompensated heart failure. How we can manage? We can manage with vasodilators and diuretics. I have already talked about vasodilators. There are different diuretics also we can use. If the patient presents with pulmonary edema, along with vasodilators and diuretics, we may use opiates, we may use oxygen, and non-invasive ventilation may become necessary. If the patient presents with acute decompensation with low cardiac output, then we may need to add on inotropic therapy, and hemodynamic monitoring is very, very important. And if the patient presents with cardiogenic shock, we need to use inotropes, and we may need to use higher level therapies like intra-aortic balloon pump, percutaneous ventricular assist device, VAD stands for ventricular assist device, and ultrafiltration may be necessary. So what are the inotropes we may use in case of cardiogenic shock? We may use dobutamine, milrinone, levosimendan, and omecamtiv mecarbil. So we need to remember the name of these drugs. What are the vasodilators we can use in case of acute decompensated heart failure? Nitroglycerin, neseritide, nitroprusside, serelaxin, and ularitide. We need to remember the name of these vasodilators. And I was talking about the diuretics in case of congestive state. We can use loop diuretics like furosemide, torsemide, bumetanide can be used for treatment of heart failure. Then next, sometimes we may use digoxin also. Digoxin should be used for symptomatic LV systolic dysfunction with concomitant atrial fibrillation. Persistent signs and symptoms of heart failure while receiving standard therapy including ACE inhibitors and beta blockers. In these cases, we may use digoxin, but it does not give any mortality benefit, no mortality benefit, and it has a narrow therapeutic window. So we always need to maintain the blood level. We should monitor for the blood level, otherwise there will be toxicity. Anticoagulation to be used in case of atrial fibrillation to prevent future stroke. Okay, if there is additional risk factors for cardioembolic stroke, we definitely need to use anticoagulation. Others like omega-3 polyunsaturated fatty acid supplementation and micronutrients like thiamine and selenium supplementation is also important. Drugs which not to be used. Statin does not show any benefit if there is no ischemic etiology. Calcium channel blocker except amlodipine. Okay, then NSAIDs should not be used. Thiazolidine should not be used because thiazolidine it increases sodium and water reabsorption, and in this way it will enhance the symptoms of congestive symptoms of heart failure. So it precipitates heart failure. It should not be used. DPP4 inhibitors, which are the one should not be used: saxagliptin, okay, and alogliptin. Saxa and alogliptin, these two drugs are contraindicated to be used in heart failure. And most antiarrhythmic drugs except amiodarone and dofetilide should not be used in case of heart failure because they may precipitate heart failure. And hormonal therapy is also not to be used in case of heart failure. Management of comorbidity is very important. So we need to manage diabetes mellitus, we need to manage hypertension, we need to manage obesity, we need to manage atrial fibrillation, we need to manage sleep apnea. So these are the most important comorbidities which we should be should be taken care of. Okay, surgery and other medical procedures may become necessary if the patient is not comfortable, if the patient is not getting relieved with the conventional management. Coronary artery bypass is necessary for a patient with myocardial infarction and coronary artery blockage. Angioplasty, same for myocardial infarction. Intra-aortic balloon pump should be used. Valve replacement to be done in cases of different valvular abnormalities. Defibrillator implantation, heart transplantation is the ultimate option. And then sometimes we may need to use left ventricular assist device and cardiac resynchronization therapy. So these are the higher level interventions to be used. Lastly, I will talk about the management of heart failure with preserved ejection fraction. So what are the drugs we use for heart failure with preserved ejection fraction? It means when the ejection fraction is more than 50%, LV ejection fraction more than 50%. So most importantly, we should be using SGLT2 inhibitors. What is it? It is sodium glucose cotransporter 2 inhibitor, SGLT2 inhibitor. Okay, and the next thing we should be using is ARNI. ARNI I have already talked about. ARNI means angiotensin receptor neprilysin inhibitor. That is the combination of sacubitril. Sacubitril is the neprilysin inhibitor and valsartan is the ARB. Okay, so sacubitril valsartan fixed dose combination to be used. And then next thing to be used is ARB, angiotensin receptor blocker. If because of cost of the medication ARNI cannot be used, it is a costly medicine. If it cannot be used, then ARB to be used, angiotensin receptor blocker to be used. And then mineralocorticoid receptor antagonist. Mineralocorticoid receptor antagonist like spironolactone, eplerenone, finerenone should be used. Okay, these are the important drugs to be used in case of heart failure with preserved ejection fraction. SGLT2 inhibitor to be used in all patients of heart failure with preserved ejection fraction until and unless it is contraindicated, and it is the first line agent for patient with diabetes and heart failure. Okay, along with this medication therapy, we need to control other comorbidities also. If the patient is having diabetes and heart failure, as I said, SGLT2 inhibitors should be the first drug of choice in this group of patients, diabetes with heart failure with preserved ejection fraction. Okay, and we need to control the blood sugar as well. The target should be less than 7 to 7.5% in case of mild to moderate heart failure. In case of severe heart failure, it should be 8 to 8.5%, and for elderly also we can keep the target at a little higher level, that is 8 to 8.5%, below 8 to 8.5%. Okay, and if the patient is suspected to have, or if the patient is having diabetic nephropathy or diabetic kidney disease DKD, we may use ACE inhibitors, we may use ARBs, okay, for to retard the progression of diabetic kidney disease. Now in case of obesity and diabetes, if the patient is obese and patient is having diabetes, we may use drugs like GLP-1 receptor agonist. Okay, glucagon like peptide 1 receptor agonist can be used. Okay, And if the patient is having atrial fibrillation, beta blockers and non-dihydropyridine, non-DHP calcium channel blockers to be used, and we may add on with digoxin. Okay, and as I have already said, anticoagulation will be necessary to prevent future stroke attacks. Okay, so beta blockers, non-dihydropyridine calcium channel blockers, and digoxin addition and anticoagulation is necessary for atrial fibrillation with heart failure with preserved ejection fraction patient. Okay, then hypertension, we need to control the hypertension in patient with heart failure, because hypertension precipitates heart failure. The target systolic BP being less than 130 in patients of heart failure, 130 millimeter of mercury. And then the drug of choice will be ACE inhibitors, then ARBs. Okay, these are the important drug of choice. Diuretics, if there is congestive heart failure, we need to use diuretics. Okay, so these are the important drugs to be used, and these are the important comorbidities to be taken care of. So this was all about heart failure which I wanted to discuss today, the management and the diagnosis part of heart failure. I'm sure it will be very helpful, and these informations are taken from the latest guideline of American Heart Association, AHA, American Heart Association. So it will be very beneficial for you. Thank you so much for attending the class.